All right. So you may ask why calcium phosphorus is in the nephrology section. That's a good question. That's all I got. I don't have the answer either. But hopefully, I really, over the years as I've developed this talk, try to focus on some core concepts, which I think hopefully will carry you through this portion of the curriculum. All right, so I want you to understand the basic physiology of calcium phosphorus regulation. We'll be discussing the different causes of calcium phosphorus derangements in infants and young children, and then talk a fair amount about rickets. So a few things just in terms of interpreting your serum calcium lab level. So it's important to recognize that there are two different primary fractions of calcium when you look at the total calcium. The first is the protein-bound, largely albumin-bound fraction of calcium. So the bound calcium is really inactive. It has no physiologic impact at all. And then you have your unbound or ionized fraction, and most of you know about the ionized calcium levels. So this is the calcium that has the physiologic electrolyte effect that we all talk about. So therefore, there are a few things that can affect your total calcium level, including your serum albumin. So if you have low albumin levels, then the bound fraction of calcium will be low because you lack the binding protein. However, your ionized fraction in these patients typically is normal. So even though their total calcium is low, they are not clinically hypocalcemic. Same thing goes for a high albumin. If your albumin is high, you'll have more bound calcium, but once again, your ionized fraction should be normal, and so clinically, they should not have any manifestations of calcium derangements. One other factor to keep in mind when interpreting your total calcium level is the pH. So in acidosis states, you'll have high levels of protons, this is acidosis, and those hydrogen ions will competitively bind with albumin. What that means is that more of the serum calcium will actually not be bound, and so that will actually increase your ionized fraction. So patients that have a normal total calcium but who are acidotic actually will have a higher ionized fraction of calcium and will be clinically hypercalcemic. The reverse goes for alkalosis. So in alkalosis, you lack protons, which means that will be the increased binding of calcium to albumin because there's no other competition with protons. And therefore, your bound fraction will be higher, and these patients will be clinically hypocalcemic because their bound fraction will be low. So this slide and the next couple slides are kind of the core of my talk. And if you can be awake for just these 2 minutes and then kind of zone out, you'll get maybe 80% of this talk. So really, again, this is kind of the basics of calcium phosphorus metabolism, calcium phosphorus physiology in the body. And so the primary players are PTH, and then the end organ targets of PTH, which are kidney, bone, and gut. So if you look at the effects of PTH, on the bone, PTH will cause bone resorption, which will release calcium phosphorus into the blood. At the kidney, PTH will cause some calcium reabsorption in the tubule, but the dominant effect is significant phosphorus wasting through the urine, so it actually will dump phosphorus out of the body. In addition, PTH will stimulate vitamin D hydroxylase activity and vitamin D activation in the kidney to increase levels of calcitriol or activated vitamin D. Last, in the gut, PTH will cause enteral calcium absorption, and this is largely facilitated through the activation of calcitriol. So calcitriol has a target at the gut and causes enteral absorption of calcium. This last effect is critically important because the gut is the only source of positive calcium balance. And so while you may have release of calcium from bone, you're just shifting the calcium stores. And so if you have any sort of calcium loss, the only source of that is going to be through the gut through the effect of calcitriol. So the net effect of each of these is that you will increase your serum calcium, again through the release of calcium from bone, absorption of calcium through the tubule, and a significant absorption of calcium through the gut. You will decrease phosphorus. Even though you're releasing some phosphorus from bone, again, the phosphorus wasting effect from kidney is dominant. So you have huge amounts of phosphorus wasting, which will decrease your serum phosphorus. And you will increase your calcitriol levels, again, through the renal activation of vitamin D. So therefore, it makes sense that the triggers for PTH would be the opposite of each of these. So low calcium will trigger PTH, a high phosphorus will trigger PTH, a low calcitriol level will trigger PTH, and PTH will then correct each of these through its normal physiologic effect. As you go through the talk, you will see many examples of, as we talk about different diseases, if you take it back to this model and map it through, find where the defect is, and look at the downstream effects, hopefully it will help you understand each of these rather than trying to memorize them in a rote manner for the boards. All right, first talking about hypercalcemia. There are a few different categories of etiologies, which we'll go through one by one. The manifestations of hypercalcemia in infants, it can be asymptomatic, but again, the classic description is this neuromuscular irritability. So they may have myoclonic jerks, this twitching or an exaggerated startle reflex, and in severe states, they certainly can have seizure. A few other symptoms, they may have apnea, vomiting, and laryngospasm. So this neuromuscular irritability is often described with these two very classic signs, right? So the first is the Schwostek sign, right? So you're stimulating the facial nerve, causing contraction of the facial muscles on that side, again, that neuromuscular irritability. And the same thing for the ulnar nerve. So if you actually apply a blood pressure cuff and inflate it, you will stimulate the ulnar nerve and cause contraction along that nerve innervation, which is called Trousseau's sign. For early onset hypocalcemia, this occurs in the first few days of life. And so the risk factors are largely due to the issues around birth. So infants that are premature or have very low birth weight, these patients have low calcium stores, often have a blunted PTH response, they have decreased renal activation of vitamin D, and they often have very rapid bone growth because, again, they're still growing very, very quickly. And for all these reasons, they can develop hypocalcemia very early. There are also maternal risk factors, including maternal diabetes, which can diminish the infant's PTH release. In addition, if there's any sort of perinatal asphyxia and tissue injury, that cell destruction will cause release of phosphorus into the bloodstream, causing this hyperphosphatemia, which can then bind the serum phosphorus and cause hypocalcemia. Lastly, if there is primary maternal hyperparathyroidism, then the infant is exposed to the maternal PTH in utero, and when they're born, there actually is suppression of their own PTH gland due to that hyperparathyroid state that they were exposed to in utero. This is largely transient. As you can see, most of these are birth effects. Once they've been stabilized and have grown some, usually this is very transient with no long-lasting effects. Late onset is more around the first week of life. So this may be due to hypomagnesemia, which can blunt the PTH response, the end organ response to PTH. A high enteral phosphorus load, again, not something we really see these days. Our current formulas really don't have that very high levels of phosphorus, so something we don't really worry about too much. And then primary hyperparathyroidism, which we'll talk about a little bit more. So one of the most common causes of primary hyperparathyroidism, that's again another board favorite, is DiGeorge syndrome. You'll probably hear about this in a variety of talks this week. So DiGeorge, one acronym that is used is Catch-22. So these patients have cardiac defects, abnormal facies, thymic aplasia, cleft palate, and hypocalcemia with a 22q11 deletion. There are different phenotypes, but really for the boards, the primary phenotype that we know about, the pharyngeal phenotype, is what we classically describe for DiGeorge. There are secondary causes for DiGeorge. So these are a variety of intrauterine toxicities, which can come from maternal diabetes, maternal alcohol use, or maternal retinoic acid exposure. But of course, the most common cause is this 22q11 microdeletion, seen in estimated up to 85% of patients with DiGeorge will have this defect. So any infant that you diagnose with hypoparathyroidism should be evaluated for DiGeorge. So this evaluation would be a T-cell immunity analysis because, once again, of the thymic aplasia, and a cardiac evaluation, an echo to look for cardiac defects, structural defects. There are associated endocrinopathies, including hypothyroidism and growth hormone deficiency. Other causes, certainly you could have surgical damage or removal of the parathyroid gland, not very often, but potentially with thyroid surgery, you can injure the parathyroid glands incidentally. You can have infiltration of the parathyroid glands by iron, through iron overload, copper, or through malignancy. As I mentioned previously, hypomagnesemia can impair both PTH secretion and PTH end organ action. And then there are a variety of genetic defects which can cause hypoparathyroidism. There is an isolated genetic hypoparathyroidism, which can be due to a variety of genetic defects. The first is an activation of the calcium sensing receptor. So the calcium sensing receptor is a negative feedback mechanism for PTH. So once again, hypocalcemia will trigger PTH, and once you correct that with higher levels of calcium, that should suppress your PTH from being released because you've corrected the defect. So that is the function of this sensor. So it senses calcium and therefore should turn off PTH. If you have an activating mutation, it basically means that PTH is always suppressed, irrelevant to the calcium levels. So that would be a defect causing decreased levels of PTH production and hypoparathyroidism. You can have a defect in the PTH gene, so you cannot produce PTH. And lastly, you can have defective embryogenesis where you don't actually create PTH glands. There are a variety of complex syndromes, again, multi-organ syndromes, which can also cause hypoparathyroidism, DiGeorge, as we mentioned, autoimmune polyglandular syndrome type 1, and this HDR syndrome, which I have on here to be thorough, but I've never seen before. Autoimmune hypoparathyroidism, so isolated as we mentioned. So this APS, really the triad is hypoparathyroidism, mucocutaneous candidiasis, and adrenal insufficiency. In the classic scenario of APS, they often will have mucocutaneous candidiasis early in life, and then usually in childhood develop the hypoparathyroidism, and then Addison's disease later on. Pseudo-hypoparathyroidism. So generally speaking, pseudo, when we talk about pseudo, what that usually means is end organ resistance. So the hormone, the trigger is present, but the targets are unable to respond to that hormone or that trigger. And so that's true here. So with pseudo-hypoparathyroidism, they have end organ resistance to PTH, meaning the kidneys and the bone do not respond to PTH appropriately. So these patients, they act like they're hypoparathyroid. They have low calcium levels, they have high phosphorus levels, but they have very high levels of PTH because PTH is continually stimulated because it's trying to correct these electrolyte defects, but it's unable to, again, because of the end organ resistance. One thing that's important with this diagnosis is something called genetic imprinting. What this means is that the transmission of a genetic defect, whether it's maternal or paternal, can affect the phenotype of a disease state. So for this specific genetic defect, this GNAS1, the maternal transmission results in something called Albright's hereditary osteodystrophy. So they have a very typical appearance of round faces, short stature, short digits, they're obese and they have developmental delay, and they have pseudo-hypoparathyroidism. They have the end organ resistance to PTH. Alternatively, if they have paternal transmission of this genetic defect, they have all the phenotype of of Albright's hereditary osteodystrophy, but they have none of the endocrine defects. So they have the appearance, but their PTH function and their calcium phosphorus actually are normal. And that's through the paternal transmission of this GNAS1 mutation. So this is called pseudo-hypoparathyroidism. All right, switching gears to hypercalcemia. Again, a variety of etiologies, and we'll go through these one by one. So the first is benign familial hypercalcemia. Kind of descriptive, it's benign, it runs in families, and the calcium is high. So it is an autosomal dominant disorder. It can be associated, we think, with severe neonatal hyperparathyroidism, but in large part, this is often an incidental diagnosis through just lab screening for other reasons. These patients do have low urinary calcium excretion, and when you measure their PTH level, it is elevated inappropriately in the context of this hypercalcemia that they have. Usually the hypocalcemia is relatively mild, maybe in the 11 range, and for that reason, again, as I mentioned, largely asymptomatic with a very benign long-term history for these patients. The cause, we believe, is a mild inactivating defect in the calcium sensing receptor. Again, we talked about this with hypoparathyroidism. If you have an activating defect, then you're continually suppressing PTH, right? This is that negative feedback gene that is active, you're always suppressing PTH. In this situation, you actually have an inactivating defect, right? So despite higher levels of calcium, this gene is defective, so it cannot turn off PTH secretion. So you have ongoing and inappropriate PTH release, and therefore ongoing effects causing your hypercalcemia. Again, we believe this to be a mild defect, which is why the levels of PTH and calcium are relatively low, not as severe, I should say, just mildly elevated, and therefore usually don't have a lot of clinical symptoms. For primary hyperparathyroidism, so again, if you go through that initial pathway, thinking about excess levels of PTH, what are the end organ effects? You have unregulated bone demineralization, you have very high phosphorus tubular wasting, you have very high calcitriol activation, and therefore you have very high enteral calcium absorption, causing hypercalcemia, hypophosphatemia, and again, very high levels of calcitriol with unregulated production of PTH. Usually in children, this is idiopathic. As I mentioned previously, it can be a tumor effect, which actually stimulates the PTH gland to release PTH excessively. And as I mentioned, you can have a more severe defect. So if you have actually complete resistance of the calcium sensing receptor, then you will have complete unregulation of PTH release that cannot be suppressed by higher calcium levels. Williams syndrome, certainly a board favorite. The prevalence is estimated to be 1 in 20,000 births. The defect is a microdeletion in 17q11. These patients have mild developmental delay. They're often described as having this cocktail personality, very outgoing, very chatty, very friendly. The cardiac defect is a supravalvular aortic stenosis, and they're described as having an albumin facies, often with dental abnormalities. These patients very often have an idiopathic, relatively severe hypercalcemia in the first year of life. They can have very high calcium levels, and we really don't understand why this happens. When measured, their PTH levels often are normal. Now, you could argue actually a normal PTH in the context of a high calcium could actually be abnormal because it should be suppressed. But we really truly don't understand the actual cause of their hypercalcemia. Thankfully, in most patients, it is spontaneously self-limited. Usually by age 2, the hypercalcemia just resolves and goes away and never recurs. Hypercalcemia of malignancy. So this can complicate up to 20% of cancers. Very often this hypercalcemia is very severe, very clinically significant. Usually this is a very large or disseminated malignancy when you have hypercalcemia as a result of it. There are a few different possible causes. The first is that the malignancy itself could produce a PTH-related protein. So this is a peptide that has an end organ effect of PTH, but is actually a little bit different and not produced by the parathyroid gland. You can have ectopic activation of calcitriol, often in granulomatous disease or lung malignancy. So you can have elevated levels of calcitriol, again, will cause increased enteral calcium absorption and hypercalcemia. And then you could have direct bone invasion of the malignancy through metastases, causing bone destruction and hypercalcemia that way. Vitamin A or D intoxication. I mentioned these. Clinically, these are very rare because the levels of nutritional intake have to be extraordinarily high. We're talking about 10,000 units of vitamin D per day or more to really cause hypercalcemia as a result of excess vitamin D intake. For vitamin A, you need ridiculous amounts of vitamin A. There are some case reports of patients that have extraordinarily high levels of liver intake, actually developing vitamin A toxicity, and subsequent, again, the bone disease that results from that. These patients can have this keratinemia, which is this yellowing of the skin. The important distinction from jaundice is that these patients actually have normal sclera, so they don't have the scleral jaundice that you would see with liver disease. All right, and then the last topic we have is rickets. So rickets are bone mineralization defects in the growth plates. This can be due to impaired vascular extension into the growth plates, but is most often due to calcium phosphorus deficiencies, leading to poor bone mineralization at the growth plate sites. Clinical manifestations, once again, the dominant manifestations are bone and cartilage deformities. So the actual skeletal defects are a little age-related based on the amount of weight bearing these children do. So in the infants, we have the classic flaring of the distal radii and the distal tibia that you see here. In toddlers who are just starting to weight bear, often you'll have developed very severe bowing of the legs or genu varum. Once children are more weight bearing, you actually may have more of this knock-kneed or turn inward appearance called genu valgum. This is the classic ricketic rosary that's described with patients with rickets. So this is flaring of the growth plates within the rib cage, within the ribs. You can have delayed fontanelle closure, once again due to poor bone development. And in some patients, this actually can be quite painful. They can have very significant distal bone pain. Some extraskeletal manifestations. This includes enamel hypoplasia. They can have decreased muscle tone. Depending on the cause for the rickets, if they have significant hypocalcemia, they may develop neurologic symptoms with seizures. And these patients in severe states do seem to have some levels of immune suppression and can be at risk for some infections. So there are really two categories of rickets. There's hypocalcemic rickets and hypophosphatemic rickets, and we'll go through each one. So vitamin D deficiency causing rickets. This is pretty straightforward and really not that uncommon. So this is once again due to poor intake of vitamin D or vitamin D production, and this is really due to infants being primarily breastfed without supplementation and or low sun exposure, which is Ohio. This also may be due to decreased hepatic hydroxylation, so I didn't mention this too much, but vitamin D, after the initial intake, it is first activated in the liver and then goes to the kidney for the second step of activation. So if you have chronic liver disease, you will lack the activation of vitamin D, which can clinically show as vitamin D deficiency. And then with chronic kidney disease, once again, the second step in vitamin D activation can also lead to a clinical vitamin D deficiency picture. The treatment is pretty straightforward. So does breastfeeding cause rickets? The answer is it can. So as you can see here, if you compare, you can see that the levels of vitamin D in breast milk are really far lower than what we actually have in formula, and far below what an infant really needs for normal bone health. So over time, there's been an increasing focus on the need for vitamin D supplementation. So initially, the thought was 200 international units a day would be sufficient, but the general recommendation now is 400 units a day would be the appropriate amount of supplementation for an infant who is breastfed, and this should start in the first week of life, really right away. In the adult literature, there's actually recommendations for higher levels, but the pediatric recommendations remain the same. Next is calcium deficiency rickets. This is almost never seen due to the prevalence of nutrition and infant formula in the US. This is really something that we don't see here. So it is really what is described. They have nutritional calcium deficiency. They don't get enough calcium in. Usually these patients will have normal levels of vitamin D, and they will have high levels of calcitriol. Again, walk through it again. They have calcium deficiency. They are hypocalcemic. This will trigger PTH. The high levels of PTH will then increase calcitriol activation in the kidney. So you have high levels of calcitriol. However, the end effect of calcitriol, once again, is targeting the gut, wants to absorb enteral calcium, but there is no enteral calcium. That is your problem. So you have very high levels of calcitriol, but you're unable to correct your hypocalcemia because there's no enteral calcium to absorb. Treatment, very straightforward. Give them calcium. Next, vitamin D dependent rickets. So this is a little bit misleading in the name because, again, this is different from nutritional deficiencies. So vitamin D dependent rickets indicates that there's a lack of calcitriol due to a defect in the 1-alpha hydroxylase enzyme in the kidney. So the kidney is unable to activate calcitriol due to a genetic defect. So these patients have normal levels of 25 hydroxy vitamin D, but they have very low levels of calcitriol because, once again, they cannot activate it. And again, going through that pathway again, if you lack calcitriol, then you have no enteral absorption of calcium, right? Therefore, you cannot absorb calcium. You'll develop hypocalcemia, which then will trigger PTH, causing bone resorption, causing phosphorus wasting. Again, you're trying to activate calcitriol to correct your hypocalcemia, but you cannot. So again, if you draw the pathway, you have a block there, and therefore causing the unregulated hyperparathyroidism, which causes your rickets. Typically, these patients have very severe rickets. Manifestations are very early in life. They can have very severe hypocalcemia. Once again, they have zero or very limited enteral calcium uptake, so they have a very negative calcium balance, and so they develop a calcium deficiency very rapidly, leading to tetany. Treatment is still very easy. You just give them calcitriol as a supplementation. You bypass the need for the renal activation, and it really corrects their rickets completely. Next is hereditary vitamin D resistant rickets. This used to be called vitamin D dependent rickets, but that's really a misnomer. This is a situation where they have end organ resistance to calcitriol. Okay, so meaning that they have normal production activation of calcitriol, but the gut will not respond to it appropriately. Thankfully, this is extraordinarily rare because these patients are nearly impossible to treat. The phenotype does vary widely due to the severity of this resistance. In patients that have a severe resistance, if you think about it, if they have resistance at their gut to calcitriol, they will never absorb calcium, meaning that there is no functional way to give this patient calcium. And the only way really to do this is through IV infusions. In some patients that have a partial resistance, you can overwhelm them with very, very high levels of calcitriol to get some enteral effect. But if they really have a full defect where they will not respond to calcitriol, the only way to provide them with calcium is actually IV. And then something that we deal with every day is this So this is chronic kidney disease, metabolic bone disease. So this used to be called renal osteodystrophy. This is what I learned about in fellowship. That really, osteodystrophy is actually a path diagnosis based on bone biopsy. And so what is a better clinical description is a term we use called CKD-MBD, or metabolic bone disease. Really the same thing. So this is Rickets secondary to chronic kidney disease. So in our patients, they actually have kind of a wombo combo of defects that cause very, very severe hyperparathyroidism. So the initial defect is that due to chronic kidney disease, decreased GFR, decreased kidney function, they will have diminished phosphorus excretion, and so they will start to accumulate phosphorus in their blood, causing hyperphosphatemia. In addition, once again, because we're talking about kidney disease, they will have decreased hydroxylation of vitamin D, decreased activation of calcitriol, and will have low calcitriol levels. Because of the low calcitriol levels, once again, there will be no triggering, no stimulation of enteral calcium absorption because you lack calcitriol, so they develop hypocalcemia. So they have hyperphosphatemia, low calcitriol levels, and hypocalcemia. And so it's not unusual for our patient to have levels of PTH that are in the multiple thousands. Very, very severe hyperparathyroidism and Rickets can develop in these patients. So this is basically a summary slide of everything that we talked about. So if you have a patient who has hypocalcemic rickets, the first step would be to check their 25-hydroxy vitamin D level. If this is low, then it probably is nutritional, right? So a breastfed infant without supplementation, the easy solution is give them vitamin D as a supplement. If their 25 level is normal, then you check the calcitriol level, check the activated vitamin D level. If that is low, once again, that might be due to either chronic kidney disease or could be due to a defect in the hydroxylase producing calcitriol. In those patients, you just give them calcitriol and correct that defect there. If their calcitriol level is elevated, potentially they could have a calcium deficiency. Again, a very uncommon diagnosis in our current state here. But if the calcitriol levels are very elevated, this could indicate resistance to calcitriol. Again, a very rare diagnosis of calcitriol resistance, which again causes very poor enteral uptake and really needs those calcium infusions to maintain their calcium balance. All right, my last topic is hypophosphatemic rickets. This is a relatively obscure topic, and I will be honest that the only questions I've ever seen on this are that hypophosphatemic rickets are caused by renal phosphorus wasting, meaning they have low phosphorus, and you treat them by giving them phosphorus. So if you need a 5-minute break, I'm going to turn off your head for a few minutes. I'm going to go through all these details of the different pathways by which this occurs, but again, all I've only seen is low phosphorus from the kidney, you give them phosphorus, there you go. All right. So that being said, this map kind of summarizes all the possible diagnoses of hypophosphatemic rickets. So a lot of this focuses on fibroblast growth factor 23. One of the effects of FGF23 is that it induces renal phosphorus wasting. Okay, it is a factor that actually facilitates the kidney to dump phosphorus. So PTH actually will stimulate FGF23 production, and that will cause the renal phosphorus wasting. And so various defects around the regulation of FGF23 is what will cause this chronic hypophosphatemic state. And we'll go through each one by one. So the first is hereditary hypophosphatemic rickets. This has been described as vitamin D resistant rickets, which is not untrue in that these patients don't respond to vitamin D, but you could also call it penicillin-resistant rickets because vitamin D has nothing to do with this diagnosis at all. So it really is just an entire misnomer because this is a phosphorus issue and has nothing to do with calcium or vitamin D. So once again, this is renal phosphorus wasting, and there are a variety of specific genetic defects that can cause this state. So the first is X-linked dominant, estimated incidence in 1 in 20,000 births. So this is a defect in the FEX gene, which is on the XP22 gene. So this FEX gene codes a peptidase that is responsible for breaking down FGF23. Once again, FGF23 causes renal phosphorus wasting. So if you have a defect in an enzyme that's supposed to break down FGF23, you're going to have very high levels of FGF23 because you have nothing to break it down. And therefore, you have unregulated phosphorus wasting. These patients then dump and dump and dump phosphorus, which leads to the hypophosphatemic state. So they lack the breakdown enzyme for FGF23, causing unregulated renal phosphorus wasting and hypophosphatemia. Usually these patients develop rickets more around weight-bearing age, and again, because this is X-linked dominant, there is no gender difference in their phenotype. These patients, again, from the calcium side of their regulatory axis is really pretty normal. The calcium is normal, PTH is pretty normal, calcitriol typically is normal, and again, the primary treatment, again, is to give phosphorus. Then we have autosomal dominant hypophosphatemic rickets. So this is an activating mutation in the FGF23 gene, and so the effect of FGF23 is increased. And once again, the effect of FGF23 is caused that renal phosphorus dumping in the urine, and so you again have chronic hypophosphatemia through unregulated renal dumping of phosphorus. Next, you have an autosomal recessive disease. This is a mutation in this DMP1 gene. This gene will cause increased production of FGF23. Again, same idea here. You have this FGF23 factor. This defect will cause increased production of FGF23, so once again, you will have very high amounts of unregulated renal phosphorus wasting, causing hypophosphatemia and rickets. There's a diagnosis of tumor-induced osteomalacia. So this is exogenous production of FGF23 from the tumor itself. Same type of situation, excess FGF23 activity causing renal tubular wasting of phosphorus and hypophosphatemic rickets. The last diagnosis is hypophosphatemic rickets with hypercalciuria. So this is actually a pathway a step down from FGF23. So this is an actual defect in the phosphorus transporter within the tubule itself. So because the transporter is defective, the tubules actually cannot absorb phosphorus, regardless of the regulatory factors before it. Okay, so these patients have basically complete dumping of phosphorus. They cannot reabsorb phosphorus at all. For unknown reasons, these patients often have actually high levels of calcitriol, and this can result in hypercalciuria due to increased calcium, enteral absorption of calcium. So once again, if you go back to this summary, we focus a lot on FGF23 itself. Again, this is the factor that causes hypophosphatemia, so the regulation of this is really what the issue is. You can have, let's see where I am here. So again, the X-linked dominant, this is a defect in the peptidase that's supposed to break down FGF23, causing unregulated levels of FGF23. You have the autosomal dominant, which is actually upregulates the activity of FGF23, causing the same effect. Autosomal recessive, causing a defect in this gene, which increases the production of FGF23. And then with tumor-induced osteomalacia, you have a situation where you have exogenous production of FGF23, all of which cause phosphorus wasting. The last is this hereditary hypophosphatemia, and this is a defect in the transporter itself, so that the tubules cannot reabsorb phosphorus, causing phosphorus wasting. Once again, the summary effect, all these diagnoses, waste phosphorus, low phosphorus, you can't mineralize bone, you have rickets, you treat them all with phosphorus in the end. All right, a few questions. The first, you diagnose hypocalcemia in a 1-week-old who has some jerking movements. You continue your evaluation with an echocardiogram. What else should be done as part of your evaluation? A renal ultrasound, review of maternal serologies, T-cell subsets, or a vitamin D level? Good. So obviously here we're talking about DiGeorge. Okay, so thinking about what is associated with DiGeorge, one of the main concerns is thymic aplasia causing T-cell issues. This is likely not going to be a board type format, but I wanted to once again emphasize the physiologic pathway and the way to kind of think through some of these problems. So if we could in the back, give them an extra 5 seconds before they start the timer, because this is a little bit involved. So what types of labs would you expect to see in a child with benign familial hypercalcemia? So once again, think about the disease, where's the defect, and then what are the downstream effects of that defect? Just kind of walk through that end organ effect of what you're managing. Okay, let me start the timer. Okay. So the answer is A. So one of the things here is to recognize what the defect of this disease is. Okay, so this is benign familial hypercalcemia. Remember, this is a mild defect in the calcium sensing receptor, so you have the lack of negative feedback. So what that means is that you have relatively unregulated PTH production. So these patients have mild hyperparathyroidism, which is what causes their hypercalcemia. But because, again, they have this ongoing hyperparathyroidism, if you think about the other effects of PTH, well, again, you're going to be demineralizing bone, causing the hypercalcemia. You're going to cause renal phosphorus wasting. Okay, remember that you have PTH. That should actually cause dumping of phosphorus because you have high levels of PTH present. So you should have low phosphorus in these patients. And once again, you have PTH present, so you should have activation of calcitriol. Right? So you have high levels of PTH, so that should stimulate the 1-hydroxylase in the kidney, and you should have high levels of calcitriol from that standpoint. Okay? So again, identify the defect, walk through your pathway. Hopefully that should help you with a lot of these different scenarios. And that's it.